1 wrong preservative, 1 microscopic contaminant, 1 miscalculated microgram. That's all it takes for an intrathecal injection to go from life-saving to life-threatening. Welcome to the most critical and misunderstood area of sterile compounding, intrathecal drug preparation. Whether you're a pharmacist, nurse anesthetist, or pain specialist, this is the one video you can't afford to miss. We're breaking down the science, safety, and step-by-step strategy behind preparing intrathecal medications, from methotrexate to morphine, baclofen to bupivacaine, all with clinical precision and real-world insight. This isn't just a tutorial, it's your ultimate reference guide. So grab your gloves, scrub in, and let's raise the bar for safe, evidence-based compounding. Let's go intrathecal. Safely, smartly, and surgically precise. So, why intrathecal? Why go through the complexity, the strict regulations, the razor-thin margins for error, just to deliver medication into the spinal canal? The answer lies in one word: precision. Intrathecal administration means we're delivering the drug directly into the cerebrospinal fluid, the CSF that bathes the brain and spinal cord. No detours, no dilution, no systemic guessing game. It's the ultimate fast-track route. Why? Because it bypasses the blood-brain barrier, one of the body's most selective and restrictive gates. Most IV drugs can't penetrate it. Intrathecal drugs don't need to. They go straight to the target tissue. This direct access allows for rapid central nervous system action. Seconds count in the operation room. Minutes matter in neuro-oncology. And when managing intractable pain or spasticity, we don't have time or tissue to waste. But it's not just about speed, it's about safety. Because the dose goes right where it's needed, we can use a fraction of the systemic dose. That means less toxicity, fewer side effects, and more targeted pharmacodynamics. Clinically, intrathecal therapy shines in 4 key areas. 1. Cancer, especially for CNS involvement in leukemia or lymphoma. 2. Infections, where pathogens invade the meninges. 3. Severe or chronic pain, when oral opioids fail. And 4. And spasticity, especially in conditions like multiple sclerosis, cerebral palsy, and spinal cord injury. In short, intrathecal isn't just another route. It's a life-saving strategy that demands the highest level of care, skill, and pharmacologic expertise. And in the rest of this video, we'll show you exactly how to do it right. When it comes to intrathecal drug compounding, there is zero margin for error. We're not just preparing medications, we're delivering them into the central nervous system, an area where the tiniest mistake can lead to permanent harm or death. Let's start with rule number 1. No preservatives. Period. Intrathecal medications must be preservative-free. Why? Because substances like benzyl alcohol, parabens, and phenol, commonly found in multi-dose vials, are neurotoxic. Even a trace amount of these additives, when introduced into the CSF, can cause seizures, paralysis, or fatal CNS toxicity. If it's not labeled preservative-free, it should never go intrathecal. Rule number 2. Everything must be sterile and pyrogen-free. We're delivering directly into a space that has no immune defense. That means even the slightest microbial contamination can result in devastating meningitis or arachnoiditis. Your ingredients, syringes, diluents, and final product must be 100% sterile and endotoxin-free. No exceptions. Rule number 3. Follow USP 797 and 800 standards. Compounding must be performed in a certified cleanroom or isolator environment, following USP 797 for sterile preparations, and USP 800 for hazardous drugs like methotrexate or cytarabine. This includes 1. ISO Class 5 laminar airflow hoods. 2. Proper gowning and glove technique. 3. Environmental and personnel monitoring. And 4. Validated cleaning protocols. Rule number 4. Match the CSF pH as closely as possible. The normal CSF pH is around 7.3. If your formulation is too acidic or too alkaline, it can cause chemical meningitis, severe discomfort, or neurotoxicity. Use buffering strategies if needed, but always verify pH during compounding when drugs require it. Rule number 5. Use the correct diluent every time. For intrathecal medications, the only acceptable diluents are 1. Preservative-free normal saline, that is 0.9% sodium chloride, and 2. Sterile water for injection. Never use bacteriostatic water or multi-dose vials for dilution. Always confirm the product is labeled preservative-free and is from a trusted source. These 5 golden rules aren't just recommendations. They are the foundation of safe, legal, and clinically sound intrathecal practice. Stick to them, and you're protecting your patients and your license. Break them, and you're gambling with lives. When preparing drugs for intrathecal administration, sterile technique isn't just good practice, it's an absolute requirement. This is a high-risk preparation going into a space that has no ability to fight contamination. So let's break down the sterile compounding gold standards every clinician and pharmacist must follow when preparing these critical medications. First, all intrathecal preparations must be compounded under a Class 5 primary engineering control, either a laminar airflow hood or a compounding aseptic isolator. These environments provide a unidirectional flow of HEPA-filtered air, removing 99.97% of particles equal to or larger than 0.3 microns. That's the air purity standard that protects your compound and your patient from microbial contamination. This Class 5 workspace must be located inside an ISO Class 7 buffer room, a controlled cleanroom where particle counts, airflow, pressure, and humidity are tightly regulated. If you're working with hazardous drugs like methotrexate or cytarabine, the hood should be inside a negative pressure containment secondary engineering control, also ISO 7 compliant, to meet USP 800 standards. Don't let your body be the contamination source. You must wear full personal protective equipment at all times. That includes sterile gloves, non-shedding gown, hair cover and beard cover, face mask, and eye protection, and for hazardous drug compounding, a chemotherapy-rated gown and double gloving. Gowning must be done in the correct order, in a designated anteroom, before you ever step into the buffer zone. Beyond use dating is not the same as expiration dating. It depends on the risk level of compounding, sterility assurance, and storage conditions. For intrathecal drugs, we're typically working at high risk or immediate use levels. That means short beyond use datings, often 24 hours refrigerated, or 1 hour at room temperature, unless validated otherwise. Label everything clearly. Include drug name and concentration, beyond use dating, storage conditions, lot number, and initials of the compounder and checker. Aseptic technique is non-negotiable. This means no touch contamination, frequent glove disinfection, proper syringe and needle handling, and minimizing air turbulence or talking during compounding. And don't forget, if it isn't documented, it didn't happen. Log every step: preparation time, ingredients and lot numbers, beyond use dating calculations, and final checks and sign-offs. Sterile compounding is a system of discipline, precision, and vigilance. The central nervous system cannot tolerate shortcuts. If you wouldn't inject it into your own spinal canal, don't inject it into anyone else's. Let's begin with methotrexate, a cornerstone in intrathecal chemotherapy, used widely for central nervous system prophylaxis in acute lymphoblastic leukemia, non-Hodgkin's lymphoma, and meningeal metastases. Methotrexate is often the first drug clinicians think of when they hear the term intrathecal. And for good reason. Rule number 1. Methotrexate for intrathecal use must be preservative-free. Multi-dose vials or formulations with benzyl alcohol are absolutely contraindicated for spinal administration. Even a trace amount of preservative can cause neurotoxicity, seizures, or death. Dosing depends on protocol and patient factors. 1. For adults, the typical dose ranges from 10 to 15 mg as a flat dose. And 2. For pediatric or body surface area-based regimens, we use 12 mg per square meter. Always round with caution. Never exceed protocol limits, especially in pediatric oncology. Dilution must be done using either preservative-free normal saline or sterile water for injection. The choice of diluent may depend on institutional protocol or drug compatibility with other agents in combination therapy, like in triple intrathecal therapy with cytarabine and hydrocortisone. Methotrexate, once compounded intrathecally, is stable for up to 24 hours when stored at 2 to 8 degrees Celsius, and protected from light. It's critical to label the preparation with dose, diluent, time of preparation, beyond use date, and proper storage instructions. Why intrathecal? Because systemic methotrexate doesn't reliably cross the blood-brain barrier. In CNS leukemia, leukemic blasts can hide in the meninges, safe from IV chemotherapy. Intrathecal methotrexate ensures we reach those sanctuary sites. It's also commonly used as prophylaxis in high-risk leukemia and lymphoma protocols, to prevent CNS relapse. And in some settings, it's used therapeutically when malignant cells are already detected in the cerebrospinal fluid. To summarize, preservative-free, properly diluted, precisely dosed, and stringently stored. Methotrexate is powerful, but only in the hands of those who respect its potency. Next up, cytarabine, a cornerstone in intrathecal chemotherapy protocols, particularly for acute leukemia and lymphoma with CNS involvement. Also known as RSC, this antimetabolite is one of the most frequently used agents for preventing or treating central nervous system relapse. The standard intrathecal dose for cytarabine ranges from 30 to 50 mg, administered as a bolus injection directly into the cerebrospinal fluid. In pediatric protocols, you may see age or body surface area adjusted dosing, but for adults, that 30 to 50 mg window is the clinical sweet spot. For sustained activity, there's also a liposomal formulation known as depocyte. This form slowly releases cytarabine over time, allowing dosing as infrequently as once every 2 weeks, 50 mg per dose. It's a game changer in reducing the frequency of lumbar punctures or Ommaya reservoir access, especially in maintenance or prophylactic regimens. Cytarabine is a key player in triple intrathecal therapy, combined with methotrexate, hydrocortisone. Together, These agents provide broad coverage against CNS leukemic infiltration and help reduce inflammation caused by chemotherapy. Always confirm compatibility, pH range, and use freshly compounded solutions to reduce the risk of precipitation. One of the biggest challenges with cytarabine is stability. Once drawn up for intrathecal use, cytarabine should be administered within a few hours. Most protocols recommend using it immediately or within 4 to 6 hours if refrigerated. Degradation can compromise both potency and safety, so this is not a compound you prepare and let sit. A major clinical warning: arachnoiditis. This is a painful, potentially disabling inflammatory condition of the spinal arachnoid membrane. It can occur following intrathecal chemotherapy, especially when multiple agents are combined. Watch for headache, back pain, nausea, and lower limb weakness or sensory changes. If suspected, treatment may involve steroids, supportive care, and discontinuation of intrathecal agents. Cytarabine, when compounded and administered properly, is a powerful CNS-directed therapy. But as with all intrathecal drugs, it requires strict attention to sterility, timing, and patient monitoring. Respect the drug, follow the protocol, and stay alert to its risks. Let's talk about two drugs that are often overlooked, but absolutely critical, in the intrathecal setting: hydrocortisone and thiotepa. First up, hydrocortisone sodium succinate. This glucocorticoid is used not as a primary antineoplastic agent, but as a synergistic and anti-inflammatory component in triple intrathecal therapy. The typical dose, between 15 and 50 mg, depending on patient age, protocol, and co-administered agents. Its main job is to reduce meningeal inflammation, which can be triggered by cytotoxic agents like methotrexate and cytarabine. Think of hydrocortisone as the buffer agent, calming the storm inside the CNS. Now on to thiotepa, an alkylating agent with a unique profile in CNS-directed chemotherapy. It's less commonly used than methotrexate or cytarabine, but when it is, it plays a potent, direct antineoplastic role, especially in leptomeningeal carcinomatosis. Dosing typically falls in the 10 to 15 mg range. Preservative-free only, of course. There is no room for additives when injecting into the CSF. But here's the catch: thiotepa is extremely unstable. Once reconstituted, the solution must be used within 1 hour. That's it. After that, chemical degradation compromises both efficacy and safety. And it's also light sensitive. Exposure to light can accelerate breakdown, so you need to protect it from light at all times. Use amber syringes, wrap with foil, or store in opaque containers. And don't forget, thiotepa is a hazardous drug. You must compound and handle it using USP 800 precautions. That means working in a negative pressure chemo hood, using chemo-rated gloves and gowns, proper waste disposal in HD-labeled containers, and meticulous decontamination after use. Never treat thiotepa like a routine injectable. This is high-risk material with high stakes. In summary, hydrocortisone controls inflammation. Thiotepa targets CNS malignancies directly, but both require precision, timing, and absolute sterility. Prepare with care, monitor closely, and always verify compatibility and timing before administration. When managing central nervous system infections, few tools are as critical, or as dangerous, as intrathecal antibiotics. Among them, vancomycin and gentamicin are two of the most powerful agents in our arsenal. but they come with significant risks. Let's start with vancomycin, a glycopeptide antibiotic targeting gram-positive organisms, especially MRSA and resistant Streptococcus species. When used intrathecally, dosing typically falls between 5 to 20 milligrams, depending on the severity of infection and the patient's age or CSF volume. But here's the catch. You must reconstitute it using a preservative-free diluent. Vancomycin is only safe for spinal administration when it is completely free of additives. Once prepared, the solution must be sterile, pyrogen-free, and ideally pH adjusted to minimize irritation to the meninges. The primary concern with intrathecal vancomycin is neurotoxicity, including chemical arachnoiditis, seizures, and encephalopathy. Symptoms can be subtle or delayed, so close neurologic monitoring is essential. Avoid mixing with other agents unless compatibility has been validated. Always verify osmolarity and pH before injection. Now let's talk about gentamicin, an aminoglycoside that's often reserved for gram-negative CNS infections, such as Pseudomonas or Enterobacter species. Typical intrathecal dosing ranges from 4 to 8 milligrams, and like vancomycin, it must be preservative-free and freshly compounded in a sterile environment. Here's where it gets even more critical. Gentamicin is both ototoxic and neurotoxic. Even at low doses, it can cause hearing loss, vestibular dysfunction, peripheral neuropathy, and in rare cases, irreversible damage. Unlike IV administration, where the blood-brain barrier offers some protection, intrathecal gentamicin reaches peak CSF concentrations directly, so you must dose conservatively and adjust based on CSF drug levels when possible. CSF sampling may be necessary to ensure therapeutic yet non-toxic levels, especially in patients receiving repeated doses or those with altered CSF dynamics. Also important, never administer concurrently with other nephrotoxic or neurotoxic agents intrathecally unless clinically justified and documented. Infections in the CNS demand aggressive treatment, but intrathecal antibiotics like vancomycin and gentamicin must be handled with precision, respect, and ongoing vigilance. The risks are high, but when used correctly, these agents can save lives and protect the most vulnerable part of the human body. Now let's shift our focus to two powerful yet rarely used intrathecal agents, amphotericin B and colistin. These drugs are reserved for life-threatening, treatment-resistant CNS infections, where every microgram matters and every second counts. First, amphotericin B, an antifungal agent with potent action against Cryptococcus, Candida, and certain molds, often used in fungal meningitis, particularly in immunocompromised patients. Intrathecal dosing typically ranges from 0.1 to 0.5 milligrams, making it one of the lowest dose and highest risk compounds in the intrathecal arsenal. The preferred formulation for intrathecal use is the liposomal version, such as AmBisome, due to its reduced neurotoxicity and better CSF tolerability compared to conventional deoxycholate forms. Always confirm with infectious disease guidance before selecting the formulation. Here's the critical point. Amphotericin B must be used immediately after preparation. Stability is poor, and degradation can lead to ineffectiveness or increased neurotoxicity. The drug must be reconstituted under strict sterile conditions, preservative-free, and protected from light. Never store for later use. Even in expert hands, amphotericin B carries a high risk of headache, nausea, seizures, and chemical meningitis. Patients must be closely monitored after administration, and supportive medications, such as corticosteroids or antiemetics, may be needed. Now let's talk about colistin, also known as cholestyramine sodium. This polymyxin antibiotic is often used as a last resort for multi-drug resistant gram-negative infections, including Pseudomonas, Acinetobacter, and Klebsiella species. Typical intrathecal dosing is between 10 to 20 mg, depending on the pathogen, patient age, and CSF clearance rates. Intrathecal colistin is most often used in post-neurosurgical meningitis or ventriculitis, particularly when the causative bacteria are resistant to all other classes of antibiotics. Its use is typically guided by infectious disease teams and often delivered via Ommaya reservoir or lumbar puncture. Colistin is not benign. It carries risks of neurotoxicity, including paresthesias, ataxia, or seizures. Chemical ventriculitis and systemic absorption can lead to nephrotoxicity, even with localized dosing. Close monitoring of renal function, neurologic status, and CSF cultures is essential. Always document indication, dosing logic, and clinical justification. To summarize, amphotericin B is dosed at 0.1 to 0.5 mg IT, liposomal preferred, use immediately. Colistin is dosed at 10 to 20 mg IT for resistant gram-negative meningitis. Both are high-stakes drugs, prepared with precision, administered with caution, and monitored with vigilance. When it comes to intrathecal analgesia, few agents have the pedigree and versatility of morphine sulfate. This is the gold standard opioid for intrathecal administration, backed by decades of use in managing chronic pain, cancer-related pain, and postoperative analgesia. Intrathecal morphine is incredibly potent. A dose as small as 0.2 to 1 mg can provide 24 hours of pain relief. To put that in perspective, that's 1/100th the typical IV dose. Why? Because intrathecal delivery bypasses the blood-brain barrier, delivering morphine directly into the cerebrospinal fluid, and from there, it acts on spinal opioid receptors. The dose must be titrated with extreme caution, especially in opioid-naive patients or those with compromised pulmonary function. As with all intrathecal drugs, only preservative-free morphine sulfate should be used. Preservatives like benzyl alcohol or parabens are neurotoxic and can cause devastating complications, ranging from chemical meningitis to permanent neurologic injury or death. Always verify the label. Preservative-free must be clearly indicated on the vial or syringe. When compounded under sterile conditions using USP 797 standards, intrathecal morphine is relatively stable, up to 30 days when stored at 2 to 8 degrees Celsius in a sterile, sealed container. This stability makes it ideal for implantable pumps or scheduled bolus dosing protocols, particularly in palliative care or advanced cancer pain management. Ensure accurate labeling of drug name and concentration, beyond use date, storage instructions, and initials of the compounder and verifier. Morphine sulfate remains one of the most effective agents for intractable chronic non-malignant pain, cancer-related neuropathic and somatic pain, spinal cord injury pain, and end-of-life symptom management. It's often the backbone of intrathecal pain pump regimens, frequently combined with other agents like bupivacaine, clonidine, or ziconotide, depending on the patient's pain profile. When compounded safely, dosed precisely, and monitored carefully, intrathecal morphine sulfate offers powerful, targeted pain relief with minimal systemic side effects. But always remember, with potency comes responsibility. In the intrathecal space, even micrograms matter. Now let's explore the high-potency intrathecal opioids, hydromorphine, fentanyl, and sufentanil. These agents are essential in precision pain management, where speed, potency, and patient-specific targeting are key. Let's begin with hydromorphine, a semi-synthetic opioid that's approximately 5 times more potent than morphine on a per milligram basis. The typical intrathecal dose ranges from 0.05 to 0.5 milligrams, making it ideal for patients who are morphine intolerant, experiencing dose-limiting side effects, or requiring longer duration spinal analgesia with a slightly different receptor profile. Hydromorphine provides less histamine release, smoother intrathecal profiles, and extended pain relief, especially when infused through implanted pumps. Next, fentanyl. This synthetic opioid is known for its rapid onset, short duration, and excellent lipid solubility. Intrathecal dosing typically falls between 10 and 25 micrograms. Fentanyl diffuses quickly through the lipid-rich spinal cord tissue, offering almost immediate analgesia, which makes it ideal for labor epidurals, post-operative pain protocols, and acute breakthrough pain in advanced disease. However, because of its short duration, usually 1 to 4 hours, it's not often used alone for chronic pain. Instead, it's used in combination regimens, often alongside longer-acting agents like morphine or local anesthetics. And now, sufentanil, one of the most potent opioids available for intrathecal use. Its potency is approximately 5 to 10 times greater than fentanyl, and 1,000 times greater than morphine. Intrathecal dosing typically ranges from 1 to 10 micrograms. That's right. Micrograms, not milligrams. A single decimal error here could be catastrophic. Sufentanil is reserved for highly specialized use cases, such as obstetric anesthesia, spinal analgesia in high opioid-tolerant patients, or ultra-low volume infusions via programmable pumps. Its rapid onset, combined with high potency and limited CSF spread, makes it a precision tool, but also a high-risk agent. One universal rule applies to all three: only use preservative-free formulations. Preservatives like benzyl alcohol, chlorobutanol, or parabens are neurotoxic and have no place in intrathecal compounding. Formulations must be preservative-free, sterile, pyrogen-free, and compounded under USP 797 and 800 standards. In summary, hydromorphine dosed at 0.05 to 0. mg, reliable and longer lasting. Fentanyl dosed at 10 to 25 micrograms, fast onset, short action. Sufentanil dosed at 1 to 10 micrograms, ultra-potent, low-volume precision. Each drug brings unique pharmacokinetics, receptor dynamics, and clinical applications to the table, but all require precise dosing, expert preparation, and rigorous safety oversight. When it comes to intrathecal local anesthetics, two agents dominate the field: bupivacaine and ropivacaine. These long-acting amide-type anesthetics offer profound sensory and motor blockade, without the systemic side effects of opioids. But they're not interchangeable, and each comes with specific pharmacologic considerations. Let's break it down. First, bupivacaine, a potent, long-acting sodium channel blocker that provides deep spinal anesthesia and long-duration analgesia, especially effective for surgical anesthesia, post-operative pain, and cancer-related pain syndromes. Intrathecal bupivacaine is typically compounded as a 0.25% to 0.5% preservative-free solution, with total injection volumes of 1 to 2 milliliters. At these concentrations, bupivacaine produces intense sensory block, and, depending on the dose and baricity, can also induce motor block, making it ideal for lower abdominal, pelvic, or lower limb procedures. But here's the warning label you can't ignore. Bupivacaine is cardiotoxic at high doses. Even small systemic absorption, especially from accidental intravascular injection, can trigger hypotension, bradycardia, seizures, or even cardiac arrest. That's why bupivacaine must be administered only as preservative-free, in carefully titrated doses, by clinicians trained in neuraxial anesthesia and resuscitation protocols. Now let's talk about its cousin, ropivacaine. Also an amide-type local anesthetic, ropivacaine is structurally similar to bupivacaine, but it has a key advantage, a better safety profile. It's less lipid-soluble, which means it causes less motor block and lower cardiotoxicity, even at higher concentrations. That makes it an attractive option for intrathecal analgesia in labor and delivery, continuous spinal infusions via implanted pumps, and patients at risk for hemodynamic instability. Typical concentrations range from 0.5% to 1%, preservative-free, and dosing should always be individualized based on the patient's body habitus, pain source, and other intrathecal agents. Whether you're compounding bupivacaine or ropivacaine, keep these points front of mind. Always use preservative-free formulations. Ensure pH compatibility when mixing with opioids or clonidine. Prepare under USP 797 and 800 conditions. Label clearly with concentration, volume, beyond use date, and all necessary sterility indicators. Never substitute one for the other without adjusting for potency, duration, and toxicity profiles. In summary, bupivacaine is used as a 0.25 to 0.5%, long-acting, but watch for cardiotoxicity. Ropivacaine is used as a 0. to 1%, safer alternative with similar efficacy. Both are cornerstones of intrathecal pain management and spinal anesthesia, but they demand respect, precision, and advanced clinical judgment. Next up in our intrathecal toolkit, lidocaine, an amide-type local anesthetic with a long-standing history in both anesthesia and diagnostics. When used intrathecally, lidocaine is compounded as a 1% to 2% preservative-free solution. The preservative-free designation is absolutely critical, because commercial multi-dose vials often contain methylparaben or benzyl alcohol, which are highly neurotoxic when introduced into the subarachnoid space. The compounding process must follow USP 797 standards, ensuring the preparation is sterile, pyrogen-free, and isotonic, with appropriate labeling and beyond-use dating if stored for short-term use. Unlike bupivacaine or ropivacaine, lidocaine is short-acting, with an onset time of under 5 minutes, and a duration of spinal anesthesia typically lasting 60 to 90 minutes, depending on dose and baricity. This makes it ideal for brief procedures that don't require extended sensory or motor blockade. But perhaps its most valuable role today is diagnostic. Lidocaine is often used in trialing spinal catheter systems or programmable intrathecal pumps, to evaluate drug flow and CSF circulation, patient tolerance to neuraxial drugs, and to rule out hypersensitivity or abnormal spread of local anesthetics. In pain management, lidocaine can also be administered intrathecally to help differentiate neuropathic pain from nociceptive components, especially in cases of complex regional pain syndrome, abbreviated as CRPS, or failed back surgery syndrome. While generally well tolerated, lidocaine's rapid CNS penetration can lead to tinnitus, perioral numbness, or even seizures, if inadvertently given intravascularly or in excessive doses. Always aspirate before injection, monitor for adverse neurologic signs, and ensure resuscitative equipment is immediately available, especially in high-risk or elderly patients. To recap, regarding concentration, it is used as 1 to 2% preservative-free only. It is used in diagnostic trials and short spinal blocks. Regarding duration, it has a fast onset and is short-acting. Regarding compounding, it must be sterile, preservative-free, and carefully labeled. Though it's no longer a frontline agent for extended spinal anesthesia, lidocaine remains an indispensable tool for safe and strategic intrathecal assessment. Beyond traditional opioids and local anesthetics, we enter the realm of non-opioid intrathecal adjuvants. Agents like clonidine and ketamine, which modulate pain through non-classical pathways and offer powerful synergy in refractory pain syndromes. Let's begin with clonidine, a selective alpha-2 adrenergic agonist, administered intrathecally at doses of 15 to 30 micrograms. Its mechanism of action is fascinating. Clonidine binds to presynaptic alpha-2 receptors in the dorsal horn of the spinal cord, inhibiting norepinephrine release and dampening pain signal transmission at the level of the spinal cord. But where clonidine truly shines is in synergy with opioids. When combined with morphine or hydromorphine, clonidine enhances analgesia while reducing the required opioid dose, which in turn decreases side effects like respiratory depression or constipation. Clinically, clonidine is used for neuropathic pain, cancer pain, spasticity-related discomfort, and even for intrathecal pump therapy in pediatric patients, where opioid sparing is critical. Clonidine is generally well tolerated, but it can cause hypotension, bradycardia, and sedation, especially in opioid-naive or elderly patients. Always monitor blood pressure closely post-administration and titrate slowly when initiating chronic infusions. Only preservative-free sterile formulations should be used in the intrathecal space, compounded under USP 797 guidelines with meticulous attention to sterility. Now let's talk about a game-changer in refractory pain, ketamine. Used at 0.25 to 1 mg intrathecally, ketamine acts as a non-competitive NMDA receptor antagonist, disrupting central sensitization and wind-up phenomena seen in conditions like complex regional pain syndrome, phantom limb pain, neuropathic cancer pain, and opioid-tolerant pain states. In fact, ketamine is one of the few agents that can reverse opioid tolerance and prevent the progression of central pain amplification. But ketamine's use intrathecally comes with significant caution. Its neurotoxicity profile is not fully understood, and only preservative-free formulations, free of benzethonium chloride or chlorobutanol, should ever be considered. Most published intrathecal use has occurred under compassionate or experimental protocols, and it should always be reviewed in conjunction with pain specialists, anesthesiologists, and institutional ethics or IRB oversight, depending on jurisdiction. It is not FDA approved for this route, but in palliative care and end-of-life settings, It has offered life-changing relief when other options fail. To summarize, clonidine is dosed at 15 to 30 micrograms intrathecally. It is an alpha-2 agonist, which enhances opioid effects. Remember to monitor hemodynamics. Ketamine is dosed at 0.25 to 1 mg intrathecally. It is an NMDA antagonist, used for severe, refractory pain. Remember to use it with extreme care. Both agents represent the future of multimodal spinal analgesia, offering deeper control with lower opioid burden. But they demand clinical precision, clear documentation, and team-based decision-making. Now we shift from pain control to spasticity management. And the cornerstone of intrathecal antispasmodic therapy is baclofen. Intrathecal baclofen is most commonly used to treat severe, treatment-resistant spasticity in patients with multiple sclerosis, cerebral palsy, or spinal cord injury. When oral baclofen fails, or causes intolerable side effects, intrathecal administration offers targeted, high-potency relief with minimal systemic exposure. The only FDA-approved product for this route is Leorasol Intrathecal, a sterile, preservative-free baclofen solution specifically formulated for spinal delivery. It's important to note that standard oral or intravenous baclofen preparations must never be used intrathecally. They often contain preservatives or are not pH-balanced for CSF, posing significant neurotoxic risk. Before long-term intrathecal therapy is initiated, patients must undergo a trial dose, typically 50 to 100 micrograms via lumbar puncture. The goal of the trial is to assess clinical responsiveness to the drug, degree of muscle tone reduction, and any adverse neurologic or hemodynamic effects. The response is usually seen within 30 to 60 minutes, and the effects can last up to 8 hours. If the patient responds favorably to the test dose, they may proceed to long-term maintenance therapy, delivered via implanted programmable infusion pump. Maintenance doses typically range from 100 to 800 micrograms per day, although some patients, especially those with severe cerebral palsy, may require higher dosing. The infusion is continuous, with the pump adjusted to meet individual needs over time. Bolus capability may also be programmed for breakthrough spasticity episodes. Intrathecal baclofen is administered exclusively through an implantable pump system, such as the Medtronic Synchro Med 2 device. The pump is surgically placed in the abdominal wall, with a catheter tunneled into the intrathecal space, usually at the lumbar level. Refills are done percutaneously, often every 1 to 6 months depending on reservoir size and dosing needs. Pump programming must be done by trained clinicians, and strict sterile technique is essential during all refills and access procedures to prevent CNS infections. Intrathecal baclofen is incredibly effective, but it comes with serious risks if mismanaged. Sudden interruption of therapy, catheter malfunction, or pump failure can cause acute withdrawal, leading to rebound spasticity, high fever, altered mental status, rhabdomyolysis, and in extreme cases, organ failure or death. Patients and caregivers must be educated to recognize early warning signs of withdrawal and carry emergency information about their pump system at all times. In summary, formulation: Leorasol is administered intrathecal only. It should be preservative-free and sterile. Do a trial with 50 to 100 micrograms bolus to assess response. The maintenance dose is 100 to 800 micrograms per day via programmable pump. Its indications include multiple sclerosis, cerebral palsy, and spinal cord injury. It is critical to avoid abrupt withdrawal. It can be fatal. Intrathecal baclofen is one of the most powerful tools in managing severe spasticity, providing targeted relief and restoring function for thousands of patients worldwide. Now let's walk through the compounding process overview, a critical sequence that underpins both clinical safety and regulatory compliance in intrathecal drug preparation. Every compounding process begins with order verification. Confirm that the prescriber's order includes the correct drug name and formulation, patient-specific dose and frequency, route of administration explicitly labeled as intrathecal, and the clinical indication, such as refractory cancer pain, spasticity, or CNS prophylaxis. This verification should be done by a licensed pharmacist and, ideally, double-checked against institutional protocols and known compatibility charts. This cannot be emphasized enough. Only preservative-free, sterile, pyrogen-free ingredients are suitable for intrathecal administration. Why? Because agents like benzyl alcohol, parabens, or chlorobutanol, found in many multi-dose vials, are neurotoxic and can lead to arachnoiditis, seizures, or fatal CNS injury when injected into the spinal canal. All components, actives and diluents, must be single-use vials labeled preservative-free and sourced from manufacturers with documented sterility assurance. The actual compounding must occur in an ISO Class 5 primary engineering control, either a laminar airflow workbench or a compounding aseptic isolator. This hood should be located in AUSP 797 compliant ISO Class 7 cleanroom or segregated compounding area, and airflow should be unidirectional. All surfaces must be sanitized prior to each use. Personnel must wear full sterile PPE, gown, gloves, mask, and hair cover. Aseptic technique is essential. No shortcuts, no compromises. Once compounded, each intrathecal preparation must be clearly labeled with the drug name, concentration, volume, and total dose. Include the beyond use date, based on risk level, sterility testing, and storage conditions. And display storage instructions, such as refrigerate, protect from light, or use within 4 hours of opening. For high-risk CSPs like liposomal cytarabine or thiotepa, the beyond use date may be as short as 1 hour at room temperature. For morphine or baclofen pumps, beyond use dates can extend up to 30 days refrigerated, if sterility and stability are confirmed. Finally, meticulous documentation is non-negotiable. Every intrathecal compound must be logged with lot numbers of all ingredients used, full names and signatures of compounding personnel, the exact date and time of preparation, and, if applicable, batch or serial numbers for traceability. This documentation is not only a regulatory requirement under USP 797 and 800, but also an essential part of quality assurance and patient safety tracing in the event of adverse outcomes. In summary, the compounding process for intrathecal drugs must be clinically verified, sterile and preservative-free, prepared under ISO 5 conditions, accurately labeled, and fully documented for traceability and compliance. Precision at every step is the difference between life-saving care and catastrophic risk. When it comes to the central nervous system, there is no margin for error. As we continue exploring intrathecal drug compounding, we must now address a critical and often overlooked topic: incompatibilities and compounding pitfalls. While the pharmacologic power of intrathecal therapy is immense, so too is its potential for harm if even minor errors go unchecked. This cannot be overstated. Never, under any circumstances, use preserved solutions for intrathecal administration. Preservatives like benzyl alcohol, parabens, or chlorobutanol are neurotoxic when introduced into the cerebrospinal fluid. Even trace amounts can trigger chemical meningitis, arachnoiditis, or permanent neurologic injury. Only single-use, preservative-free, sterile vials are appropriate for intrathecal compounding. No exceptions. Next, be cautious of pH incompatibility. Many intrathecal drugs have narrow pH ranges, designed to match that of cerebrospinal fluid, which typically sits at around pH 7.3. Combining agents with differing pH levels, such as opioids, local anesthetics, and steroids, without a validated compatibility chart, can result in precipitation, drug inactivation, or pH shifts that irritate the meninges. Always check for compatibility data from published guidelines or compounding references before preparing multi-drug spinal admixtures. Visual inspection is another crucial safeguard. If your compounded solution appears cloudy, hazy, or contains any particulate matter, it must be discarded immediately. Cloudiness may indicate bacterial contamination, drug precipitation, or chemical instability. No medication should ever be administered intrathecally unless it is completely clear and free of particulates, even if freshly prepared. Use a 0.22 micron filter needle during withdrawal and syringe filling whenever possible, and always inspect under proper lighting and against a white background. Finally, let's talk storage. Most intrathecal preparations should be refrigerated at 2 to 8 degrees Celsius, protected from light, especially with light-sensitive drugs like thiotepa or amphotericin B, and stored in sterile, amber syringes or vials, when applicable. However, a few agents, such as liposomal cytarabine, depocyte, may have short room temperature stability windows, sometimes as brief as 4 hours. Others may precipitate when refrigerated, so always follow manufacturer guidance and published stability data. Label every preparation with exact beyond use date, storage requirements, and any cautionary notes, such as protect from light or discard if cloudy. To sum up, avoid the most common and dangerous pitfalls by remembering: no preservatives, ever. Check pH compatibility before mixing drugs. Visually inspect every solution, and store appropriately with full labeling and documentation. Intrathecal compounding is precision pharmacy. Small oversights can lead to devastating outcomes. Treat every preparation with the same caution as neurosurgery, because in many ways, that's exactly what it is. Before we wrap up, let's distill everything we've covered into the most essential points. Your key takeaways for safe, effective, and compliant intrathecal drug compounding. First and foremost, intrathecal drug compounding is a high-risk, high-impact clinical intervention. You are delivering potent medications directly into the central nervous system, bypassing the blood-brain barrier, with no second chances for error. But when done correctly, intrathecal therapy can relieve intractable pain, reduce spasticity, treat CNS infections and malignancies, and dramatically improve quality of life for patients with otherwise unmanageable conditions. This is pharmacy and medicine at the highest level of precision. Next, remember the non-negotiables. Sterility is paramount. Every product must be compounded under USP 797 or 800 compliant ISO Class 5 conditions. Dose accuracy is critical. Intrathecal errors don't just cause discomfort, they can cause seizures, paralysis, or death. and preservative-free products only. No benzyl alcohol, no parabens, no exceptions. One contaminated vial, one wrong decimal point, one unlabeled preservative can lead to irreversible harm. You must also always verify drug compatibility, especially when mixing multiple agents for pump-based therapy. Watch for pH differences, precipitation risks, light sensitivity, and stability windows. Rely on peer-reviewed compatibility charts, up-to-date compounding references, and institutional protocols validated by your Pharmacy and Therapeutics Committee. Compatibility is not just a technicality. It's the difference between therapy and toxicity. And finally, document everything. Lot numbers, personnel names, exact time and date of preparation, storage conditions, beyond use dating, and any deviations or clinical notes relevant to the preparation. Documentation ensures traceability, supports regulatory compliance, and, most importantly, provides clinical accountability. Intrathecal drug compounding is not just about preparing a syringe or programming a pump. It's about trust. Patients are trusting that the drug entering their spinal fluid was prepared with meticulous care by someone who values safety over shortcuts. Whether you're a clinician or a pharmacist, you are the gatekeeper between high-risk therapy and high-quality patient outcomes. So respect the process, master the standards, and always remember, precision saves lives. Let's walk through a snapshot of the most commonly used intrathecal agents, covering their formulation, dosing, diluents, stability, and special handling considerations. Think of this as your Swiss Army guide to spinal drug compounding. Methotrexate must always be preservative-free, with intrathecal doses between 10 and 15 mg, or dosed per body surface area at 12 mg per meter squared. Use preservative-free saline or sterile water for injection. Once prepared, it remains stable for up to 24 hours refrigerated at 2 to 8 degrees Celsius, but must be protected from light. Primarily used for CNS leukemia prophylaxis, and always from preservative-free vials only. Standard cytarabine dosing is 30 to 50 mg intrathecal, or 50 mg liposomal every 2 weeks, marketed as Depocyte. Dilute with preservative-free saline or sterile water for injection. This drug must be used within 4 to 6 hours of preparation. As part of triple therapy, watch for arachnoiditis, a painful inflammatory reaction in the meninges. Hydrocortisone is used as sodium succinate, with dosing between 15 and 50 mg. Its diluent is preservative-free saline or sterile water for injection. Stability is standard for preservative-free steroids, about 24 hours refrigerated. Serves as an inflammation moderator in combination regimens. Thiotepa is an antineoplastic dosed at 10 to 15 mg preservative-free, diluted in sterile water for injection. This is highly unstable. Use within 1 hour of compounding and keep it protected from light. It is critical to handle it as a hazardous drug under USP 800 and compound in a negative pressure hood. Vancomycin dosage range is 5 to 20 mg preservative-free, diluted in preservative-free saline or sterile water for injection. Stable for up to 24 hours refrigerated. But be alert. This drug carries a risk of neurotoxicity, so continuous CNS status monitoring is imperative. Gentamicin is administered at standard dose ranges from 4 to 8 mg preservative-free, in preservative-free saline or sterile water for injection. Stable refrigerated for around 24 hours. Because of its ototoxic and neurotoxic potential, CSF level monitoring is strongly recommended. Amphotericin B intrathecal dosing is 0.1 to 0.5 mg, with liposomal formulations preferred. Dilute in 5% dextrose solution in water and use immediately after preparation. No storage. Be aware, high neurotoxicity and light sensitivity are major concerns. Colistin is used at 10 to 20 mg intrathecal doses of colistin, methet, in preservative-free normal saline. Medically viable for up to 24 hours refrigerated. Reserved for multi-drug-resistant gram-negative meningitis, but watch for neurotoxicity and nephrotoxicity. Regarding morphine sulfate, this gold standard opioid is dosed at 0.2 to 1 mg, preservative-free, in preservative-free normal saline. Stable for up to 30 days refrigerated. Crucial best practice. Include detailed labeling of beyond use date and storage information. Hydromorphine is dosed at 0.05 to 0.5 mg. Hydromorphine is roughly 5 times as potent as morphine. It, too, must be preservative-free and refrigerated for up to 30 days. It delivers smoother analgesia with less histamine release. Fentanyl dosages range from 10 to 25 micrograms, preservative-free only, in saline. Stable refrigerated for a month. It provides rapid onset, short duration effects, ideal for breakthrough pain. Sufentanil is even more potent and is dosed at 1 to 10 micrograms, preservative-free, refrigerate for up to 30 days. Because it's ultra-potent, you need microgram level accuracy. A compounding mistake here is not just a typo. It can be catastrophic. Regarding bupivacaine, use 0.25 to 0.5% preservative-free solution, usually 1 to 2 milliliters. Store refrigerated for 24 to 30 hours. This long-acting anesthetic has excellent spinal block, but cardiotoxicity risks mean stray intravascular injection is deadly serious. Ropivacaine is safer cousin of bupivacaine, dosed 0.5 to 1% preservative-free, 1 to 2 milliliters, refrigerated for up to 30 hours. Provides strong anesthesia with a safer cardiac profile. A clinician's preferred alternative for long blocks. Lidocaine dilution range is 1 to 2% preservative-free, used for diagnostic spinal procedures. Must be used within hours, never stored. A tool for testing and diagnostics, not long-term analgesia. Regarding clonidine, administer 15 to 30 micrograms intrathecally in preservative-free saline or sterile water for injection. Stable refrigerated for 24 hours. As an alpha-2 agonist, it enhances opioids, but watch blood pressure and heart rate. Hemodynamic monitoring is critical. Ketamine is used in doses of 0.25 to 1 mg, preservative-free only, diluted in preservative-free saline or sterile water for injection. This drug has low documented stability, so use ASAP. It's a powerful NMDA antagonist. Rescue analgesic in refractory pain. Use only under specialist guidance. Regarding baclofen, implementation uses leorosol intrathecal solution. Start with a 50 to 100 microgram trial bolus, then maintain 100 to 800 micrograms per day via implanted pump. Dilution is done with a commercial preservative-free pump mix, following the reservoir-specific stability parameters. The implanted pump is crucial. Withdrawal or failure can be life-threatening. That was a fast-paced but essential breakdown of intrathecal drug compounding essentials. Precision, potency, and preservative-free accuracy are your pillars of safety when dealing with CNS injections. In the final segment, we'll reveal a downloadable summary file to keep this guide at your fingertips. And there you have it. A deep dive into the powerful, precise, and potentially life-saving world of intrathecal drug compounding. Whether you're a frontline pharmacist, a clinician in the operation room, or a student stepping into sterile compounding for the first time, mastering these principles isn't optional, it's essential. If this video brought value to your practice, hit that like button, subscribe for more advanced clinical guides, and share this video with your team. Because safe compounding starts with informed professionals. Have questions? Drop them in the comments. We're building a community of excellence, and your insight could help others. Thanks for watching, and I will see you in the next one.